Catastrophic APLA syndrome is one of the most dangerous manifestations of APS. Let's discuss how you can early recognize. Unlike classical APS, which is a single vessel thrombosis, CAPS is a rapid systemic thromboinflammatory storm. Mortality is high despite recognition, and early recognition is possibly the only way we can save the patient. So CAPS is not just about clotting. It is widespread microvascular thrombosis, cytokine-driven inflammation, and multi-organ ischemia is the rule. Think of APS behaving like sepsis. The clinical hallmark of APS is simultaneous involvement of more than or equal to 3 organs within a few days span. The speed is the key differentiator. Typical time course is hours to 1 week, where multiple organs would be failing. Organs commonly involved are system and the presentation we'll discuss. In kidney, they present as AKA with proteinuria. In lungs with ARDS or diffuse cellular hemorrhage. In nervous system as encephalopathy, stroke. In heart as myocardial dysfunction. In skin as libido and necrosis. In GI as abdominal ischemia. Multi-system failure should trigger suspicion in any patient because this is one of the commonest differentials of sepsis, albeit it is rare. The triggers are often, unfortunately, infection is a trigger, surgery is a trigger, pregnancy is a well-known trigger, withdrawal of anticoagulation is a trigger, trauma is a trigger. Always look for a recent trigger. They will be invariably present, and there will be a temporal relationship with CAPS onset. The lab clues: CAP mimics DIC, mimics TMA, thrombotic microangiopathy. So look for the feeding and the mechanism. Thrombocytopenia is due to consumption, hemolysis is due to microangiopathy, LDH is due to tissue injury, and cell lysis. Prolonged IPDT is due to lupus anticoagulant. A positive APL body is diagnostic, and D-dimer is often invariably elevated. Now, how do you distinguish with some sepsis? And actually, sepsis may be a precipitating factor. In CAPS, thrombosis is prominent, but sepsis it is variable. Cultures are negative. In CAPS, it is positive. Complement may fall in CAPS, but it is variable. APL antibodies are positive. Organ ischemia is common, but it is less common in sepsis. So CAPS is notorious. Distinction from TTP. In CAPS, ADAM-T1 is normal, APL antibodies are positive, organ pattern is multi-system with nervous system, and response to plasma exchange is partial in CAPS, but it is dramatic in thrombotic microangiopathies. Now, what are the early warning signs? Suspect CAPS when a known APS patient develops sudden multi-organ dysfunction. Rapid onset thrombocytopenia develops with organ failure. AKI with respiratory failure coexist. Skin ischemia emerges. No clear septic source is identified in a patient with suspected sepsis, and deterioration is critical and rapid. The diagnostic thinking: formal criteria include more than or equal to 3 organ involvement, rapid onset, histological microthrombosis, and persistent APL activity. But treatment should not wait for biopsy and results. Empirical treatment should be started. Immediate management principle is: think of a possible diagnosis of APS, catastrophic APS, treat like a thromboinflammatory emergency. The standard approach include anticoagulation, high-dose steroid, plasma exchange, and IVIG. Cyclophosphamide, if it is SLE associated CAPS, has got an advantage in mortality. Now, what is the pearl you want to take from this? A CAPS is often masqueraded as sepsis, DIC, TMA, and often managed accordingly. But the clue is unexplained rapid multi-organ ischemia in a prothrombotic patient. So early suspicion is the only thing that can save life in this. Thank you.